Good afternoon and welcome to today's national webinar presented by the Gaines Center with the support of the Substance Abuse and Mental Health Services Administration. And happy holidays. Whether you're observing a seasonal or religious holiday, welcome and thank you for taking time out of this busy season to join us for this event. And today we are really happy to be joined by our esteemed colleague, Dr. Mark Munitz, to talk about assisted outpatient treatment within the context of civil commitment processes. So next slide, please. I'm Dr. Melissa Stein, a Senior Project Associate here at the Gaines Center and Policy Research Associates. And I will be just opening with a few introductory remarks. Many of you know the drill. You know that I'm going to ask you to put in the chat box where you're joining from and who you are. So thank you so much for going ahead and doing that. I am joining from North Carolina. Next slide, please. And I just want to make clear that the views, opinions, and content expressed in this presentation and discussion do not necessarily reflect the views, opinions, or the policies of the U.S. Department of Health and Human Services. Next slide, please. And we do welcome your questions throughout the presentation. Please submit your questions in the Q&A pod, and we will get to as many of the questions as possible at the end of the presentation. And we will also be conducting a couple of polls, and we really appreciate your participation in those polls throughout the event. You should have just seen a poll pop up. So when you see that, just click and submit your responses. Next slide, please. We are recording this event, and anyone who registered for this webinar will receive the slides from this event, as well as a notification of when the video recording is available on the SAMHSA YouTube channel. And we will also provide a certificate of attendance at the end of this event. And just note that this is for personal use only. We are not able to issue CEU credits. Next slide, please. Thank you. We do have ASL interpretation lined up for this event, and our ASL interpreters are Stacy Starkweather and Kelly Dalrymple. We do also have live transcription available. In order to see that, just click the show captions icon at the bottom of the Zoom platform on your screen. Next slide, please. Before we dive into the heart of this webinar presentation, we are really pleased to have SAMHSA on the line to provide some opening remarks. So I will turn it over to Commander Mary Catherine Hager to provide some opening remarks on behalf of the Substance Abuse and Mental Health Services Administration. Commander Hager.
Wonderful. Thank you very much, Melissa. So I wanted to just take this time and say thank you very much for attending the Gaines Center's last webinar for calendar year 2025. Today's topic will cover AOT and its relationship to competency restoration across the sequential intercept model. AOT is an important program that can support those with serious mental illness who can't live safely on their own, and can help individuals with serious mental illness who do not recognize that they need to receive treatment. For these reasons and other public health concerns, the administration supports the AOT program as noted in Executive Order, and we look forward to you joining us in 2026 when we will have more webinars covering a wide range of topics. So just wanted to say thank you very much for joining us today, and with that, we turn it back to the moderator.
Thank you, Commander Hager. And now I'd like to introduce our presenter and speaker for today. Dr. Mark Munitz serves as Professor and Chair Emeritus of Psychiatry at Northeast Ohio Medical University. He previously served as Medical Director for the County of Summit Alcohol, Drug Addiction, and Mental Health Services Board from 1992 to 2012, where he helped develop and sustain one of the first outpatient civil commitment programs in Ohio. Dr. Munitz is also the co-developer of the sequential intercept model, which is a framework to help communities reduce criminal justice involvement of individuals with serious mental illness. And Dr. Munitz also helped plan and support implementation of coordinated specialty care programs known as FIRST programs for individuals experiencing their first episode of psychosis throughout Ohio. So we're really excited to have him with us today for this event. You know who's going to be speaking to you today. So now let's take a look and see who has joined us for this webinar today. It looks like a majority of you are joining from an urban location, followed by about 23% of you joining from suburban locations, and also a good showing from our rural locations. Welcome, everyone. And we do have a few of you joining from tribal lands, such as reservations, pueblos, or Alaska Native villages. Welcome. And then looking at where you all are joining from in terms of your organization or work, I believe our largest percentage is about 24% of you joining from our community-based providers. We also see many of you joining from crisis services. Government and policy. Also seeing many of you joining from corrections, probation, and parole, and judiciary. So thank you so much for taking time out of your day today to join us to learn about this important topic. Without further ado, I'm going to turn it over to Dr. Munitz for his presentation.
Well, thank you so much. It's a pleasure to be here and really an honor to be invited by the Gain Center and through SAMHSA to give this talk. As you'll hear, I have benefited greatly from the Gain Center as my career has, and so it's nice to hopefully be able to give back. I am in Shaker Heights, Ohio, right outside Cleveland, where it's been snowing and bitter cold for the last month. And I woke up with this cold, so I apologize for the voice, but hopefully the content will come through. I don't believe I have any conflict of interest to disclose, but I did want to indicate that I consult to PEGS Foundation based in Hudson, Ohio, and I'm a volunteer member of the National Assisted Outpatient Treatment Institute's Advisory Committee of the Treatment Advocacy Center. I don't put together slide presentations like this all by myself. I get a lot of help, and I got a lot of help with this over a period of time. And I want to acknowledge the contributors, but also make it very clear that any opinions expressed as I talk are my own completely. And I describe myself as a community psychiatrist. I do not have forensic psychiatry training. For better or worse, I think it changes one's orientation a bit. You can judge that for yourself, I suppose. So I have been asked to cover a fair amount of ground in a relatively short time. And this is what I'm hoping you will get at the end of this presentation, an ability to appreciate the complex reasons for the overrepresentation of people with serious mental illness in the criminal legal system, understand how the sequential intercept model can be used as a framework to address this problem, understand the critical role of the ultimate intercept, what's also called intercept zero, in preventing criminal legal involvement among individuals with serious mental disorders, recognize how the growth of state hospital use for competency restoration is really at a crisis level and requires a search for alternatives, and understand the role that assisted outpatient treatment, AOT, may play as a potential part of the solution to what's really a very complicated problem. So this is a slide that's probably familiar to you, at least the content of it is, that roughly 5% of the general adult population is living with a serious mental illness. And when we look at correctional populations, whether we're talking about law enforcement or jails or prisons or probation parole, it's roughly 3 times the number on average in those settings of people with serious mental illness. If you break it down by gender, it's 3 times for men and probably closer to 6 times for women who are just as involved. And about 3/4 of those individuals also have a co-occurring substance use disorder. So substance use is the rule, not the exception. So how did this come about? And a term that I used to use, and I try to avoid it now, is a criminalization of the mental illness. I think overrepresentation is the more accurate description, because it's not just a result of untreated symptomatic mental illness, although that does play a significant role, clearly. And that's complicated. So part of the reason that we have so many people untreated or undertreated in our communities is simply that our systems aren't adequate to meet the needs. I wish that wasn't true, but I think we have to take ownership that that is part of the problem. There's also the reality that not every patient responds to treatment that we have. We have not figured out how to help everyone. And so there are some people who are treatment resistant, and we need to figure out how best to meet their needs despite not being able to substantially support their recovery. And then there are the patients who are resistant to treatment, don't want to avail themselves of the treatments that we do have to offer, and that very often are very helpful to such people. And sometimes that's for very good reasons, and something we have to negotiate with our patients and figure out a way to be most helpful in providing support to someone who doesn't want our help. But there's this other group that was referred to in the introduction, the group with anosognosia, that as a result of their illness, which we view as a brain disease, they're not able to appreciate that they have the illness, and not thinking that one is ill leads one not to want treatment. That's a substantial part of the problem, but it's not the whole explanation for the overrepresentation problem. Criminologists have studied what are called criminogenic risks and needs in the general criminal justice population. There are both static and dynamic risk factors. Static things like age and gender and such. But the dynamic risk factors, meaning risk factors that can be changed, include what are listed here as the big 8. And I'm going to focus really on the top 4, because those are things that the behavioral health community doesn't traditionally recognize as being something that's in their role. History of antisocial behavior, antisocial personality patterns, antisocial thinking, as well as hanging out with antisocial associates. And I'll talk a little bit more about that as we go along. And then there, perhaps arguably the most important factors are actually social factors and public policies. Poverty. Some people would argue poverty is the #1 reason we have this problem. Homelessness, food insecurity, exposure to violence in one's community, and as well as to substance use around one's community, as well as public policies. As we've criminalized substance use disorders, mandatory minimum sentencing, and inequity stemming from policies and practices, prejudices that exist systemically. Sorry. I thought this quote that comes out of the Marshall Project, looking at Cleveland, where I'm based, was a good place to kind of start the conversation, because it really gets to the heart of much of what I'm talking about. It's a professor from Harvard, who was a former federal public defender, says a vast number of people who we sweep into the criminal system are not actually criminal in any meaningful sense. They're not scary, they're not dangerous. They do things we don't want them to do. But the American habit of labeling people criminals and then throwing them under the societal bus is very particular and very American. Goes on to say, the Marshall Project goes on to say that the cases that this professor is talking about also reveal the limitations of the county's specialty dockets. Cleveland and Cuyahoga County, like many around the country now, do have mental health courts and drug courts and co-occurring courts and veterans courts and the like, and they help a lot of people. But I think the point of this is that there are a larger number of people who don't meet the strict eligibility criteria. Most of those programs require one to volunteer, and there are lots of folks who will not volunteer, for just one example. So I've been thinking about this problem and prior to my retirement, working on it uh, for 25 plus years. And in the late 1990s, um, as medical director of the Summit County, which is the Akron area alcohol, drug, mental health board, which is essentially the mental health authority for a county of a little over 500,000 people, we started paying more attention to the fact that a lot of our patients with serious mental illness were in the county jail. And we looked closely at who was going and why, and realized that if we had opportunities to divert people to something else, half or more of the people that were showing up in jail could have been diverted to treatment and alternatives. And so we started looking at what we could do to address that. And fortunately, at that time, I believe it was 1999, the Gain Center was offering consultation to communities trying to take on issues at the interface of the criminal justice, mental health, and substance use disorder interface. And so I got the okay from my boss to apply to get a consult, and our application was accepted. And to my ultimate pleasure, Dr. Patty Griffin came to Akron from the Gain Center and consulted. She met with all sorts of people across the multiple systems. We got to know one another. She gave us a great set of recommendations, but we also began to work together thinking about how we might think about this for our respective communities and beyond. The simple observation that people move through the criminal justice system in predictable ways. It's a fairly straightforward flow. You can't get in without law enforcement and going from there. That the problem is very complicated that we're trying to solve. It could be called a wicked problem, I think, very fairly. And there's not going to be a single silver bullet solution. So we got to address it from multiple levels. And that led us to coming up together with input from Dr. Hank Stedman, who was the director of the Gain Center at the time, with the sequential intercept model. And Patty and I wrote this up, and it was published in Psychiatric Services in 2006. And it's had an impact beyond anything we could have imagined at the time. It turns out it's simple, but it's useful to lots of people, which has been very gratifying. In the article, we had two graphics to present our thinking about the model. And this is one of them that we called the funnel, which I think I get credit for or blame for. But the idea of the funnel is that the earlier in the process of going through the system, the bigger bang for the buck one would get, in a sense. There are more people that could be intercepted and diverted from the criminal justice system to the treatment system, which is the goal. And at the very top of the funnel, we described what we called the ultimate intercept, which is essentially the mental health system, mental health and addiction system, doing what it knows how to do, should do, does best. And that would prevent criminal legal involvement altogether. But for those who, nature of their illness, the nature of the communities, have contact with law enforcement, there were opportunities for diversion there. If they happen to be arrested, there were opportunities to divert shortly after arrest, at the point of initial detention or an initial hearing, and so forth through the hearing process, the forensic process, reentry from jails and prisons or hospital, forensic hospital, and then community corrections and community support. Now, 10 years later, Policy Research Associates, the umbrella organization of the Gain Center, announced the first expansion of the sequential intercept model. They introduced Intercept Zero with a focus on preventing criminal justice involvement altogether, largely focusing on the crisis system. And Policy Research Associates has this linear model separating Intercept Zero, community services, with the crisis care continuum essentially from law enforcement at Intercept One. So this came as a surprise to me at the time. And honestly, I had two reactions. One was that this was brilliant. I had actually heard from a couple of my law enforcement collaborators that they liked the term Intercept Zero. They were using it. Ultimate Intercept just didn't ring true. I think it was too wonky. So the term is great, and it brought great attention that was needed to the crisis system and our need to really enhance the crisis response system so that law enforcement and the community had alternatives to jail. But on the other hand, I was a little bit offended, honestly, that the ultimate intercept wasn't as clearly identified as it might have been as actually being synonymous with Intercept Zero. And my belief is that as important as the crisis services are, it's just one part of the whole continuum of community behavioral health services. And that in my mind, the ultimate intercept should be synonymous with Intercept Zero and be broader than just crisis services. It should be an accessible, effective, criminologically informed mental health treatment system in the community. And if we had that, we would be able to keep a majority of people out of the justice system altogether, which is our goal. And for this presentation, I added within an accountable system of care, because I've been increasingly aware that there are systems that have a lot of services, but they are so fragmented and there's no one you can point your finger at or no entity and say they're responsible for making sure that all of these entities do what needs to be done in a coordinated, integrated fashion. So I think accountability becomes really important. So I'm going to talk about Intercept Zero, or the ultimate intercept, to some degree, at some length here, starting with some basic assumptions for the mental health system as we think about those at the interface or at risk of interfacing with the criminal legal system. And the first is to expect criminal legal involvement in community mental health settings serving individuals with serious mental illness, similar to how we think about substance use disorders. Back in the dark ages when I was trained, we really totally separated the treatment of substance use from the treatment of mental disorders. If you were in one system, you thought the other system needed to take care of the problem first, a lot of finger pointing. We learned that that didn't work, and integration is the thing that's most effective. We need to think the same about folks with criminal legal involvement and not stigmatize them as different than the rest of the community mental health population. In fact, they're often a majority of the community mental health population. Studies showing prevalence of justice involvement in community mental health centers range from 25% to 71%. And I'm guessing the 50 to 71% is probably the most accurate number in most settings. We also have to consider the jail as part of the community. Again, having lived in the dark ages, there was a time when if a patient of mine went to jail, it was a vacation for me. They were being taken care of in my mind, and I didn't need to worry about them. That was wrong-headed. The jail, we need to follow our patients into the jail if they go and connect with them as they come out. And that's really a very important piece to consider. Have to tailor care and supervision based on both risk and need. And it's not just the criminogenic risks that I'm going to talk about briefly again, but the clinical risks and needs. So I'm repeating and reframing because I think it's really important that Intercept Zero is synonymous with the ultimate intercept, an accessible, effective, criminologically informed service system to meet the needs of people with serious mental illness with co-occurring disorders, including substance use. I have to mention trauma because trauma is so prevalent in our populations, and other health conditions, which are also incredibly prevalent. So addressing the primary medical needs addressing criminogenic needs and addressing social needs with an accountable entity overseeing a coordinated system of care, some sort of mental health authority, in my mind, at the local level, ideally. So I'm not an expert on criminogenic risks and needs, but this is what I've learned, and the surprise is that people with serious mental illness in the justice system actually score higher in studies that have looked at this in these criminogenic risk factors than the general population of offenders who don't have a serious mental illness. It's not clear to me if we know whether these risk factors were there prior to the justice involvement, which maybe led to it initially, or as a result of exposure to a criminal justice setting. But it underscores for me how important it is to keep our patients out of the criminal justice settings as much as we possibly can, because they're at risk of picking up really bad habits, if you will. And my colleagues and I have argued that criminogenic risk assessment and assessing areas of need should happen in our mental health settings. I call it aspirational right now. I don't think it's happening in most places, but it's something we should get training on and attempt to do. And similarly, there are interventions, cognitive behavior therapy approaches to addressing criminogenic needs that have been developed by the criminal justice folks that they are used in the general justice involved populations. There's a lot of work going on now to adapt these for routine use in the seriously mentally ill population. And we should incorporate that into our mental health treatment just as we incorporate the treatment of substance use, for example. And again, this is an aspiration. Much of what I'm talking about today actually is going to be aspirational. And then there are critical services for appropriate subpopulations that need to be available ideally in every community. And I'll start with coordinated specialty care for first episode psychosis, which probably most of you know was developed initially with research at the National Institutes of Mental Health and then supported by grants from SAMHSA. We helped start programs in our state around the same time, and it offers the possibility of bending the outcome curve in a positive way for people if they're identified as early in the process of their illness and offered comprehensive integrated care. It's very promising, but not yet available everywhere it needs to be for everyone who needs it for as long as they might benefit. In addition, long-acting injectable antipsychotic medications turn out to be far more helpful than I think we used to believe, not just for people who have trouble remembering to take their medicine, but for larger subpopulations, including first episode patients, and they're not available as much as they should be in the settings where our patients are being cared for. And even more so for clozapine, the one drug that works when nothing else has worked pharmacologically. Clozapine is still the gold standard of an effective antipsychotic. Doesn't work for everyone, but a substantial number of people who have failed to respond to any of the other antipsychotic drugs do respond to clozapine. It needs to be more available, as does medication-assisted treatment for opioid use disorder. ACT, Assertive Community Treatment, the most intensive community-based treatment programs that we have. We have evidence that it's worked. I think we're approaching a 50th anniversary of that. And it's available in many communities, but not as much as it should be because it's intensive and expensive, but it's so helpful to people, many of whom are voluntary, want treatment, but just need a lot of support. And Forensic ACT for those that have had criminal legal involvement in addition to those needs. And then finally, assisted outpatient treatment, which I will define shortly, for those who are unable to appreciate their need for treatment to which they previously responded and are unwilling to seek or accept treatment voluntarily. Now, I think this is somewhat controversial in part because there's a sense that people advocating for AOT want everybody to have involuntary treatment, and that is so far from the truth. I think it's a small subset of people who fit this broad criteria, but without intervention, they suffer a great deal and end up often in our hospitals and in our criminal justice systems, and we can do something about that by offering these programs. So this is the definition that the Treatment Advocacy Center has put together for assisted outpatient treatment. I think it's a good one. It's the practice of providing community-based mental health treatment under a civil court commitment, civil court order, as a means of motivating an individual with mental illness who struggles with voluntary treatment adherence to engage fully in their treatment plan, and focuses the attention of treatment providers on the need to work diligently to keep the person engaged in effective treatment. So it's committing a patient, but also assuring the commitment of the treatment system to meet the needs of that patient. And I used to think that we shouldn't have to commit the system should just be committed. But that's naive, I think. And our work is so hard, and there's so many patients, and it's easier to serve those who come willingly. But this is a group that desperately need our help. And if a court can help us provide that help, that's a good thing. Now, one of my mantras is that AOT is not just a court order. It is way more than a court order. An AOT program is an organized, systematic effort within a mental health system to ensure that AOT will be made available to those who need it to live safely in the community. It really needs to be a cross-system, organized effort, not just one court order. And I may offend any judges in the audience here, but a judge alone cannot pull off AOT. You need a committed treatment system at every level of the system. So just to be clear, AOT is not a criminal court process. It's not the same as a mental health court, which is for people who've been charged criminally, and it's not enforced by the threat of contempt of court or jail. We're not looking to criminalize or recriminalize. This is an attempt to decriminalize, if anything. So AOT is actually very hard to study. I've tried a bit. I'm not fundamentally a researcher, but with my own eyes, having helped start a program in Summit County, I know that AOT works when it's really done carefully and systematically. The best research that I'm aware of was done by Dr. Marvin Swartz and Jeff Swanson and his group at Duke, looking at New York State's program. New York State's program is somewhat different than most of the other states, maybe all of the other states, because it was very robustly funded, but also very robustly evaluated because of the controversy. And the conclusion of Dr. Swartz et al. Is that New York's AOT program improves a range of important outcomes for its recipients, that it does lead to increased services, which clearly improve recipient outcomes. And so critics would have argued that all you need to do is increase the services, but what the researchers have found is that in addition to the increased services, the court order and its monitoring offer additional benefits in improving outcomes beyond the intensive voluntary services. And then again, to make the point, the AOT order exerts a critical effect on service providers. It gets service providers to really attend to their patients. So I'm going to shift gears and move to the competency assessment and restoration process, and then bring the two together, hopefully, in a way that will make sense. So and it's discouraging for me to read this first bullet point because I've been reading a bullet point like this for 20 some years now, but it's still the case that about 2 million individuals with serious mental illness cycle through our nation's jails every year. Many of them, perhaps most, are charged with nonviolent misdemeanors. Michael Compton and his group in New York did a recent study that supported this statement that shows that larceny, and their example of that was shoplifting, and trespassing were among the most common reasons individuals with serious mental illness were arrested. And I would argue that those are crimes of poverty, crimes that homeless people commit. Mental illness certainly may play a role, but I think you get my point. And increasingly, these individuals are being referred for competency to stand trial assessments, found incompetent, and referred for competency restoration. So the assessments generally happen in jail, sometimes in hospitals. Restoration largely happens in hospitals and sometimes in jails. And these individuals are using limited hospital and jail resources that could be better used. So just to support what I said earlier, that this is emerging as a crisis, I think it is a crisis. 2020 survey of the states found that 82% of states indicated that referrals for competency evaluation were increasing, and 78% thought referrals for competency restoration were increasing. Been some terrific articles talking about this, all published in the midst of the pandemic in 2020. Two by Drs. Callahan and Pinels. Dr. Callahan from the Gain Center recently retired. And a third is a study of the research by Drs. Pirelli and Zoff. Worth reading when you have a chance, and you will get the bibliography at the end. But a brief summary of what's in these articles, just again indicating the fairly dramatic increase in the proportion of people in forensic hospitals. The numbers in state hospitals between 99 and 2014 increased by 76%. Now, this is 11-year-old data. I know in my state, which I'll talk about at the end, and I think in many, the numbers have only increased. Maybe in a few, they've gone the other direction. I would hope so, but I'm not sure that that's true. The National Judicial College, again in 2012, found that 60,000 competency evaluations were ordered annually, and only 20% found incompetent to stand trial. Most competency evaluations are done in jail, so it's an increasing pre-adjudication jail days. And I'm going to make the point again and again that having a person with serious mental illness in jail is not a good thing for that person. People in jail with serious mental illness often decompensate, they have relapses, they get worse, and they're also setups to be victimized, unfortunately. So, so they're in jail waiting to be assessed for competency. There's often a long wait. And then if they're found incompetent, they're transferred to a hospital where there's often a wait for that bed. Once they get into competency restoration treatment, if you will, the median length of stay was 147 days. 81%, so a large majority, are restored to competency. And in their paper, Callahan and Pinels pointed out, no studies have examined the time to restoration in comparison to treatment as usual. I'm going to declare my strong belief that it takes much longer to restore someone to competency than what treatment as usual in a hospital is nowadays. So, report out of California shows how ineffective and inefficient this process is. 3/4 of patients who were restored to competency returned to their communities, either having served short sentences or having their cases dismissed upon their return to court. A large majority, 70%, were rearrested within 3 years of discharge from the Department of State Hospitals in California. So not much good comes out of this whole revolving door competency assessment, release to the community, and do it again. And the states are at risk of being found to violate the Constitution and pay heavy fines. So there's a lot of motivation to address this, to stop people waiting in jail inordinately long times to go through the process. And it's made headlines in a number of newspapers. Again, not good PR for all involved. So I like this quote from the Vera Institute of Justice. Like is probably not the right way to put it, but I think it's apt. In lockup, we're incarcerated first and human beings second. People charged with misdemeanors, and I would argue also low-level, non-violent felonies who are not a public safety threat, spend excessive time in jails and hospitals for little yield, generally have their charges dropped, receive treatment for the purposes of competency restoration. And it's important to emphasize that that's different than treatment to promote recovery. It's education about the court system. It's not necessarily the same um, um, in, integrated mental health treatment that then connects to treatment and community resources when people leave. So they're often leaving um, ultimately jail without any connection to treatment. And they're using limited state hospital capacity that could be available to civil patients who can't find their way into the hospitals because the beds are filled with these forensic patients. And I really do believe there has to be a better way. And there's been a lot of thinking about this and a lot of work. Gain Center has, the last several years, has done a lot of work with a number of states around this issue. But I'm going to talk as I go about the role that AOT may play in helping to address the competency restoration, arguing, I think I already have, that AOT may help at the prevention level at intercept 0, but at intercepts 1, 2, and 3, the concept I'm going to talk to you about is dismissal upon civil commitment with AOT. And then it's not directly related to competency restoration at the time, but intercepts 4 and 5 can prevent recidivism so we don't go have our patients going through the revolving door. So again, intercept 0, the ultimate intercept, can play a big role in prevention. And I'm going to talk now as we go forward with early deflection or diversion at intercept 1, diversion at intercept 2, and 3 by thinking about competency assessment process a bit differently. So for those people who present a low public safety risk, and they don't need to be in the hospital, they've been arrested, but they clearly don't need to be in the hospital. There's a big push now around the country to consider outpatient restoration for individuals where that would be appropriate. And the goal is, while the outpatient restoration is happening in the community, there's a connection to the array of mental health services and supports that the person needs. And for someone who's viewed at high risk of not adhering to treatment because of anosognosia, when the whole process is over, then AOT could be used to stop the revolving door and get the person into treatment towards recovery. In circumstances where the public safety risk is moderate or high and the person's illness is stable, they don't really need to be in a hospital. They need to be in a secure setting, but not necessarily a hospital. And so in states that have secure residential treatment, that might be a more appropriate place to do the competency restoration rather than using those precious hospital beds. Not all states have secure residential treatment. Ohio, I do not believe, has that still. And there's concern that is legitimate about the quality of the services provided, as well as safety in a setting that's not under JCHO or other accreditation bodies. So I think it needs to be done carefully and thoughtfully, but it does offer an option to help free up hospital beds. So the usual process is what we ought to be doing for those people who need a hospital level of care and they need to be in a secure setting. So people who are psychiatrically unstable, likely meeting inpatient hospital civil commitment criteria, and are charged with a serious felony, as they clearly present a public safety risk if allowed to be in the community. Those are the folks for whom the typical hospital-based competency restoration process makes a lot of sense, and we're not looking to change that. What I am looking to change is for this person. And I imagine many of you know who I'm talking about. I would hear this from CIT officers, from city prosecutors, from defense attorneys, judges. I'd hear it from clinicians, and I'd hear it from family members over and over again. This person doesn't belong in jail. If they need to be in a secure setting, it needs to be a hospital. And I think this does describe a significant cohort of individuals with serious mental illness who are psychiatrically unstable and don't appear to present a public safety risk if their illness is being treated. So Intercept 1 is law enforcement and crisis services. And a lot of work has been done and is being done right now because of the emergence of 988 to train the community and 911 call takers to call 988, use mobile crisis, mental health crisis when that's available and appropriate instead of calling law enforcement. We've spent a lot of effort in Ohio to develop the Crisis Intervention Team, CIT program, which I imagine most of you are aware of. I'm a big supporter of that model. I think training officers to understand what mental illness is all about, to develop, if they don't have it, empathy. Um, and many of the officers that choose to go through CIT training are very empathic at the start. Learn how to de-escalate as best they can and refer people to treatment whenever possible rather than arrest is a valuable way of keeping people from going beyond an initial police contact. We're developing co-responder models around the country. My slides are a little bit out of order, really, but deflection versus diversion. Deflection is an interesting word to me. I think it's mostly used to talk about getting people with substance use disorders into treatment rather than jail. But I also think about deflection as what an officer might do, a CIT officer who knows his community and knows some of the people that he's had interactions with and can intervene before there's a crisis. They're not subject to arrest. They don't need to be transported involuntarily to an emergency room or a crisis center, but they need to get reconnected to treatment. And CIT officers can help to do that and can suggest all the first responders can suggest to the mental health treatment system that AOT may be useful for somebody who they keep seeing over and over again in the jail or the emergency room or behaving in a troubling way in the community. Intercept 2 is the initial booking and initial appearance in court. And I'm actually trying as much as possible to prevent that initial appearance in court and move somebody as quickly as possible. And so it's not beyond my wildest imagination that somebody can show up in the booking area of a jail and possibly the officer who transported the person or the person doing the initial screen at the jail says this person's obviously ill. Let's get them to the hospital. And maybe charges could be held in abeyance or just dropped depending on the nature of the charge. And the person could be evaluated, and if they're hospitalized, maybe the charges can be dropped if they weren't earlier. And AOT could be used post-discharge to assure continued treatment and support. That's increasingly hard to do when there are no beds in the hospitals, but it's something that I think is doable, and I think there are probably communities doing it. But now I'm going to talk about a more formal program that's in a planful way, looking at using the treatment system and the civil system as an alternative to using the criminal, legal, and the forensic system. So the idea is that there's a screening at booking that's done intentionally to identify those individuals who need to be prioritized to be assessed to determine if they meet the criteria for emergency hospitalization. For an individual who is assessed as meeting those criteria and is not being a public safety risk if their mental illness is treated. And I don't think this is as hard as it sounds because most of the people I'm talking about are what we nowadays might call familiar faces. They're people that the system knows. They're not new to the system. They've possibly been in the jail many times. They've been in emergency rooms many times. So it's not like they're being assessed cold. At that point, you have a prosecutor, ideally, possibly a judge, who agrees to drop charges with or without prejudice. The individual is rapidly transferred to to hospital using emergency civil commitment. So this is a direct transfer to a hospital. We've got a bed waiting for this person. And when appropriate, assisted outpatient treatment would be used upon discharge to assure the criminal court as well as the civil court that there's going to be continued follow-up for these folks who, if they're not huge public safety risks, they're people who are potentially very problematic in the community. They're high risk of being arrested again. So this is a heavy lift. This is not something that's easy to do anywhere, in my mind, in the US right now. But I think it's worth aspiring to, because there are all these pieces that you have to have in place, which I think are doable in a community that has developed a robust AOT program. But you have to have rapid mental health screening in the jail. You have to have the ability to assess if someone meets civil commitment criteria, and that someone, or there needs to be availability of someone who can initiate the emergency commitment process. I know this is doable in my state of Ohio. I know state laws vary widely around that process, but that's part of what would ideally happen here. Then there's timely communication of key information with a prosecutor or judge who's willing to consider dropping charges. It can actually be with or without prejudice. And then immediate access to the state hospital for jail transfers under the civil criteria, so they're no longer forensic patients. Now, it says that it could be a community or private psychiatric hospital if connected to the system. The largest growth of inpatient capacity, psychiatric capacity in the US are private freestanding psych hospitals. And a large percentage of those, especially of the new ones, are for profit. So I'm somewhat skeptical that those facilities or local general hospitals with psych units are going to be willing to take these folks who they view as criminal patients. But in a really strong collaborative community, I think it's possible. And then you need to have an established AOT program to assure continued treatment post-hospitalization. Now, you don't have to do these things in a linear fashion, and it wouldn't be a bad start to establish an AOT program and build from there. Sorry. So the key to pulling this off is trust across the system among all the stakeholders. And that's most easily done by people getting to know one another across systems. And there are many ways that can be accomplished in many communities now across the country, in part with the help of the Gain Center. Sequential intercept mapping brings cross-system folks together who can then continue to work. Their other Stepping Up initiative also is a way to bring people together and make this happen. So the advantage of doing this is that it avoids extended jail stays to allow for the competency assessment and court determination of the need for competency restoration. Again, the long stays in jail are not good for our patients. Avoids extended hospital stays for competency restoration. So I guess there's not research proving this, but just playing with numbers, and I think these are I think it's a relatively conservative number that a competency restoration stay for a misdemeanor might be 90 days. And although 15 days might not be long enough for some of the sicker patients who we really need to stabilize, but 15 days is probably longer than the average in most civil settings these days. You can get 6 civil patients cared for in that same one bed as one competency restoration bed. And using AOT and just connecting people to ongoing treatment assures the criminal justice system that the mental health system is doing what needs to be done and really can make an impact. Now, it's probably more realistic right now that a competency assessment is going to happen. But you can still use this to dismiss upon civil commitment with AOT at that point. So they're staying in jail, going through the competency assessment, but they could then be transferred to a civil hospital using the civil commitment process with AOT assuring the connection to needed care and support. And then I learned recently, actually, when the Gain Center brought its competency restoration group together, that there's some states that are now doing outpatient competency assessments for nonviolent misdemeanants who don't need to be in a hospital, which I think is a brilliant idea. Again, helping with this goal of getting people out of jail as fast as possible. Individuals coming out of jail or prison are at high risk for recidivism. If they're not connected to treatment and support, they're at high risk for dying, actually. And for those who meet civil commitment criteria, AOT should be considered prior to release if possible, possibly with an initial hospital admission, followed by AOT upon stabilization, or in some cases, it may be possible to go directly to assisted outpatient treatment in the community. So I'm going to finish up talking a little bit about my state of Ohio. Not exactly bragging, because I'm not, but we've got the problem that most of the states have. I started in this system in the early 1990s, and no one can tell me exactly what the number was, but my memory is about a third of the state hospital beds, and there were more of them then, were forensic patients. In 2002, it was 50%. In 2025, right now, the official number is 90% of Ohio's state hospital beds, or about 1,100 beds, are occupied by forensic patients. I say or higher. My colleague in Summit County, Akron, where I did the bulk of my work, tells me that there are no beds for civil patients. He can rarely get the sickest of individual into a state psychiatric hospital because it's all filled with forensic patients. The state's been working on this. A large group of people have been working on this through the courts, and we have an Attorney General task force on mental health and criminal justice. And after a lot of work in August of 2021, a bill passed called Senate Bill 2, which prohibits a court from ordering a criminal defendant from undergoing inpatient competency restoration if they're charged with a nonviolent misdemeanor. And they're given three alternative options. They can dismiss the charges, they can order outpatient restoration, or they can file an affidavit of mental illness with the probate court. And one of the important things this bill did, it made it clear that the criminal court and the probate court can talk to one another without violating anybody's privacy rights. So it's now several years later, and when I've spoken to people at the state to understand where things stand, I'm told it's still really too early to fully assess the impact. The bill as passed still requires the competency assessment, so we still have people staying in jail. It did lead to the Supreme Court of Ohio developing rules of superintendence for AOT programs for the courts, which I think from the court side is really very important. There's several counties are innovating. There's an increasing use of community-based restoration across the state, although the numbers are still pretty modest. When I ask about dismiss and refer upon civil commitment using AOT, I'm told it's in its infancy. People are thinking about it. In Montgomery County, which is the Dayton area, they have an AOT program. They have an active, probate court judge who's established local rules based on the Supreme Court of Ohio's rules. There's ongoing communication between the mental health system, the city prosecutor, and the court. But they also have no access to state hospitals. And they point out some of the problems of relying on community hospitals, which is that there are some hospitals that absolutely refuse to admit the people who need the hospital the most. They've been difficult to manage, and they just say no. In the Cincinnati, Southwest Ohio area, they've been using jail-based competency restoration. And I know there are a lot of advocates for jail-based competency restoration. I don't think it's the ideal because we're keeping people in jail for a long time, but if they're going to be in jail anyway, waiting for a bed at the hospital certainly beats not doing it in the jail while they're doing nothing. So I finish with the question for you all, and thank you again for your attention. But is this aspirational better way feasible? The various aspects of it. Some prosecutors and jail administrators I know are open to changing the current ways of doing business. I know that the police through the CIT program have a culture change, and they're very, very open to divert. Why can't prosecutors, sheriffs, and judges? And I know that they can, and many want to. Can state psychiatric hospitals hold or create beds for this process for these people? Is the vision and leadership there to make this work? And then is my skepticism undeserved for private psychiatric hospitals serving this population? And then I wonder if there are states and counties doing variations on what I'm proposing. Wonderful resource that you can all get access to, put out by the Treatment Advocacy Center is this handbook for advocates and implementers, dismiss upon civil commitment with AOT, one alternative to the competency restoration crisis. And those are the references that you'll be able to read when you get the slides yourself. And I thank you very much for your attention. At least my talk.
Okay, thank you so much, Dr. Munitz. And I hope that you take a look at the chat. We have many folks who have also expressed their appreciation for your presentation. So we do have some time for some questions now. And thank you everyone who has already submitted questions in the Q&A pod. And if you have questions, please continue to drop those into the Q&A pod. Yes, so I know many of you have asked, are we going to get slides? Are we going to get the recording? Yes. So if you registered for this webinar, you will get an email with the slides that were presented today. You will also get an email when we are able to post this recording to SAMHSA's YouTube channel. Okay, so let's dive into some of these questions. We have some really excellent questions that have come in throughout the presentation. So I'm going to try to just go through and see which ones might be the most relevant to all of you attending today. So let's see. First one, Dr. Munitz, someone posted, she said, I am a forensic court liaison in Tampa, Florida. And in her role, she routinely integrates criminogenic risk assessment as part of the broader clinical and psychosocial evaluation for justice-involved individuals. Her question is, how do you recommend sequencing or integrating substance use treatment and mental health interventions when both domains present as high need and appear to be mutually reinforcing, particularly with this court-involved population? What might be your approach?
Yeah, well, I alluded to this earlier. The mental health people used to believe that you had to treat the substance use before you could really address the mental health problem. And the substance use people thought you needed to treat the mental illness before you could address the substance use. And what we've learned is you have to treat both at the same time as best you can within the limitations of the circumstances. So ideas in the past, for example, that we're not going to prescribe any medicine for someone. We're not going to prescribe antipsychotic medicine, for example, in somebody who's actively abusing, because the abuse is counteracting the drugs. It probably doesn't make any sense. That we might not get the effectiveness that we want, but it's better than nothing. I think the most important answer is to engage the person And if ideally you would have clinicians who are trained to address both sets of problems. If not, then an integrated team working collaboratively to simultaneously address the substance use and the mental illness. I know there's controversy about court-ordered substance use treatment, and I'm not an expert on that, and I'm not convinced that that really is doable. But you can use AOT for someone who's not able to appreciate they need the mental health treatment. And with engagement and to some degree strong encouragement that some of the judges involved at the probate court level are able to do. Some of the judges are amazingly skilled at motivational interviewing, one of the approaches that we in the mental health world are trying and substance use treatment world try to learn. But I think we have to somehow try to treat as best we can both problems. And if the person's only amenable to one, then treat that one and keep working to get them to accept treatment for the other. It's the best answer I can come up with.
Okay, I think that's wonderful. Thank you. So this next question is a little bit more high level. We have folks from, with varying levels of familiarity with AOT participating in our webinar today. So this person asked, and I think a common question, isn't assisted outpatient treatment in civil commitments forced treatment for clients who have never been arrested or charged with a crime? And I think you've made it very clear in your presentation that many folks actually have been arrested or charged with a crime. So how would you help folks understand the appropriate population for AOT?
Yeah, well, so this is a civil court process, and I think everyone is used to the fact that for probably going back to the mid 1800s when psychiatric hospitals started, people were admitted to those hospitals against their will. With the civil rights movement here in the 1960s and 70s, a lot of due process was developed so that people are not locked up against their will in psychiatric hospitals without an appropriate process and without appropriate criteria around danger to self or others, or some variation of grave disability and inability to care for oneself, meet one's basic needs. AOT is an extension of that concept of civilly committing someone who has not committed a crime, has nothing to do with crime, it has to do with illness, to avail themselves of treatment that they would not avail themselves of voluntarily, even if offered in the most welcoming way. That there is a cohort of individuals, and as I say, I mean, I truly believe, and I've seen patient after patient. There was a period in my job where I sat through every civil commitment hearing for this county of 500 some thousand week after week, and I would see folks who were very ill with psychotic disorder, who responded beautifully to treatment in the hospital, but never believed that they were ill or wanted to have the treatment or accepted the treatment. No, and no matter how skillful the clinicians were trying to point out ways in which an individual could identify that they're being helped by this treatment, because we don't need someone to say I have schizophrenia to be accepted for treatment, to accept treatment for schizophrenia if they realize that the treatment helps. But there's this group of people where no matter what anyone could do would convince them to voluntarily adhere to treatment. So they'd be discharged, and a month or two later, or even less sometimes, I would see the same person back for another commitment and go through that cycle. So the assisted outpatient treatment, the concept was to disrupt that cycle and have court ordered treatment as an outpatient. Now, it's court ordered. Is it forced? It's court ordered. Is it coercive? It's court ordered. There's a certain amount of coercion to it. We try to train our clinicians and one another to be as skillful as we can to take advantage of most people's respect for the court. Most people will follow a court order if they're reminded that they're under that order. Increasingly, in many communities with AOT programs, the judge, in a sense, is part of the treatment team and sees the individual in court for what are called status hearings at various intervals, and serves as a cheerleader. And I said they use motivational interviewing skills to try to convince someone um, that they care. And sometimes the patient sees that the judge cares and thinks the judge cares more than their clinicians do. And if that gets them to accept treatment, that's okay with me, although there should be a huge effort on the clinical side to develop rapport, develop relationship, develop trust, so that the patient under the court order willingly agrees to adhere with treatment. With AOT, if someone is not adhering to treatment and they become symptomatic again, they have a relapse, then there is a process to have that person evaluated, potentially be picked up by law enforcement, ideally a CIT officer who is skillful in doing this in a way that doesn't uh, create trauma, and have the person evaluated, and if necessary, have them hospitalized if they meet hospital criteria. But that's not necessary most of the time with most of the patients. People will adhere willingly. And when it's done skillfully by both the judge and the treatment system, it doesn't feel that coercive, or in some cases at all coercive to people, other people. There's a certain amount of coercion involved, and the argument that supporters like myself have is it beats the alternative. It's, at least they're not abandoned to their psychosis and suffering in the community, not getting help that we know works. I'm not advocating to do this for people where the treatments that we have don't work. This is for people who've clearly demonstrated that they're responders.
And I think you made a point earlier in the presentation that you know the population for this service isn't that large. Like we are talking about a smaller group relatively of very sick people. Would you agree with that?
No, I do agree with that. It's actually, so, I mentioned I consult to the Treatment Advocacy Center, and one of the things they're advocating for, and have been the last couple of years, is for more research in all of this area. And one of the questions that I raised is, can we identify what is the percentage of the serious mentally ill population? If we say that's 5% of the overall population, what's the percentage that actually meet the criteria and benefit from AOT? And my belief is it's quite small when you take it as a percentage. But if you take 5% of 1 million people, that's a lot of people. And if it's a fraction of that, it's still a lot of people. But relatively speaking, this is a small minority of the universe of people with serious mental illness. The majority can be treated effectively, voluntarily, with a robust treatment system. And it's on us to build those robust treatment systems and engage folks where they are.
And we certainly, in line with the sequential intercept model, the Gaines Center really advocates for having a very strong intercept zero. So you have those robust community-based services for folks to access, hopefully before they enter, a crisis, hopefully before they enter an emergency situation, and that their families and friends can access those services as well. And I do want to just circle back to a comment that someone made in the chat, and just want to appreciate the clarification. I did misspeak, and I do not mean to say that most people on AOT have been charged with a crime. And I was thinking, it's more that many people in our criminal legal system may be experiencing a mental illness, a serious mental illness at greater rates than the general population. And sorry for that confusion, and I thank you for that clarification.
Yeah, no, thanks for clarifying that. I should have spoken to that as well, because I get concerned sometimes that there's a lot of enthusiasm to use AOT to affect the justice-involved population, and I'm all for it. But I think the majority of people appropriate for AOT are appropriate for AOT outside the criminal legal system. They may have had past exposure, but not necessarily current.
And that's our goal. We want to keep people out of the criminal legal system altogether. So, okay, so let's get to a few other questions. I believe you've answered several questions just throughout your responses to previous questions, but let me just take a look. We do see that folks are dealing with a range of challenges. So, can you speak to folks are asking when it comes to the state hospital issue and reentry, um, let me make sure I'm asking that question correctly. Actually, let me reread this. Oh, so someone asked a mental health advance directive. So how could that play into AOT and this range of services we're trying to make folks available to people?
Right. So mental health advanced directives, I think, are a great, excuse my grammar. It's a great concept, and I think systems should work hard and clinicians should work hard to encourage their patients who are capable to initiate a psychiatric advanced directive, just as all of us should have advanced directives for end of life care and that sort of thing. The problem is with you need to be competent. You need to have a decision-making capacity to initiate an advanced directive. And the bulk of the people I'm talking about don't have that capacity. So I don't think I think it's a great solution and a great tool for people, the larger number of people in the mental health treatment system, to indicate, what their wishes would be should they be admitted to an emergency room if they have a request around what hospital or facility to go to or not go to, what medication to be treated with or not, details of their history that would be important for the clinician who doesn't know them to be aware of. All of that, I think, is a great idea. There's a lot of practical issues of how to make that happen and make them available at the time of a crisis. But I think conceptually they make a great deal of sense. And it may be that there's a portion of folks who have experienced AOT who get well enough to put together an advanced directive and then can avoid the civil commitment and AOT process going forward. But it's not the total answer.
Thank you. And someone also asked, you spoke earlier in the presentation about accountability in the continuum of care and that being a feature of AOT. Can you speak to more of what that might look like? Would this accountability be legislated rules for clinical providers or funding for more system level oversight or something else entirely?
Well, the idea of funding for system oversight. So, I was in a role as the medical director of a county board, which is the mental health authority at the county level. And the way Ohio's mental health law is written, I don't think this has changed. People who meet commitment criteria and are committed by the probate court, whether it's to a hospital or um, to outpatient commitment, AOT, they're not committed to a facility. They're committed to the board. And the board is kind of a nebulous thing to commit someone to. So, but the way the statute is written, there is a person at the board called a chief clinical officer, who theoretically is is the person making sure that the person actually meets the standards for ongoing commitment, sees to it that the court is petitioned if the person no longer meets those standards, and really is responsible for making sure that the treatment provided is the appropriate treatment. Those it's expensive to have a psychiatrist have a role like that when they're not provide because there's such a great need for direct patient care. But my bias is I did this for 20 years that it was a very valuable function within a system and for a relatively large urban system, and Akron's not the biggest, an investment worth making. Within the 88 counties in Ohio today, I know one full-time person still at the Summit County Board, the wonderful person who took my job when I left. And the rest of the state does not have a psychiatrist in that kind of oversight leadership position. I think it's a mistake. I know there are practical reasons why it happens, but at some level, someone who has the right level of knowledge and influence, um, being able to oversee and coordinate at a level which, to me, generally a city or county level makes the most sense. In some places, it might be at the state level, and it may well be that state mental health authorities could do this in smaller states or more widely um, frontier or rural states. But someone, I believe so. I'm a proud member of the National Alliance on Mental Illness, and I think talking to the NAMI folks, that I'm also a parent, that a NAMI member, family member, should be able to know who they can call when things aren't working, not for the specific clinical issue, not knowing who the doctor or the case manager is, but knowing who to call, who can have an impact on the system not working, because that's most often what's the problem, in my opinion. So I don't. So it is a funding issue to some degree, and it's probably a philosophical issue also, in terms of willingness to think about who that person would best be. And I'm saying person. I mean, if there's an entity, and it doesn't have to be a single individual. But I think the concept of a mental health authority, be it at the state or local level, I think it's a role for government. Honestly, there probably are ways it could work in smaller communities where a clinical leader at a mental health center could take on a role like this. But it'd be complicated to not have conflict of interest in doing that. So it needs to be somebody who's objective.
And we've seen the Gain Center and working with various communities, we've seen the role of the judge also be part of that accountability structure where if you don't have a state or county level entity to supervise, then the judges often would step in when a treatment provider was not doing or adhering to the court order. So we have seen, at least in one jurisdiction, I saw a treatment provider be held in contempt for not actually following what the court order said for that person's treatment. So there are many mechanisms, I think, that are opportunities for jurisdictions to explore under how to hold accountability across the systems.
Yeah, it's an interesting idea. And as I said, with AOT, the judge is holding the treatment system accountable,
Mhm.
uh, but not everyone's on AOT.
Right. Just under the AOT program. That's
Yeah,
right.
that's right.
So last question before we go into some closing slides. So we know that the treatment piece is one of the most critical. So the judge is a very important part of AOT. The treatment is also critical, and many communities use assertive community treatment modalities. Can you speak to ACT and its role in AOT programming, or if there are other modalities communities should be thinking about?
Sure. I mean, so I know that there are communities that have sort of taken a position that anybody on AOT ought to be on an ACT team. Um, my experience in Summit County, we had ACT teams, and we had people on the ACT teams on AOT and people on the ACT teams voluntarily who were not under court order. But we also had people on AOT who we didn't feel, and when I say we, it's the clinical treatment team, didn't feel needed that level of intensive services. There are some people who, when the judge says you must follow the treatment plan, who really do follow the treatment plan. And when they're treated, they're quite highly functional, do not need all the supports of an ACT team. And so I think it's a misuse of resources to assume that everybody who needs AOT needs an ACT team. And certainly everybody on an ACT team doesn't need AOT. It's matching the individual's needs with available services. And so that's my position. And we did an attempt at a study that's published in Psychiatric Services a number of years ago, not methodologically sound, but just taking advantage of available data that supported the observation that people on AOT did quite well with or without ACT, and kind of I think support the position that I'm expounding, that not everyone needs ACT, but there's some where that's essential. Absolutely.
Regardless of the model you use, please think about fidelity to that model. And that's where we also see folks falling through the gap, is when communities say we're using an ACT team or this kind of team or this kind of service, but they're not implementing it with fidelity. You may also see challenges there. So
Absolutely.
okay. Well, thank you so much, Dr. Munitz, for your time today in the presentation, as well as answering these questions. If we could go to the next slide, we will start to share just a little more information. So for those of you looking for a certificate of webinar attendance, we'll be dropping a PDF for that. I believe we'll be dropping that in the chat. And I think that may also come to you in an email. I'll let the team verify that in the chat. And we'll go to the next slide, please. If you have not joined the Gaines listserv, we will be able to add you to the listserv. If you go to this shortened URL, just type that into your favorite browser and then enter in the relevant information. I think it's just your name and email address. And that listserv will connect you with all the resources, opportunities coming out of the Gaines Center, whether it's webinars like this, publications, and we do provide a quarterly newsletter, so it won't fill your inbox too much, but we welcome you to join that listserv. Next slide, please. And we do have some upcoming things for you to think about. If you are interested in learning more or working more on assisted outpatient treatment, we do have 2 learning collaboratives coming up. So we are still in the early conceptual phases of determining exactly what these learning collaboratives might look like, but we do have some things that are in the works. And these opportunities would be appropriate for communities planning, launching, or strengthening their AOT programs. So if you are interested in learning more about joining a group that will be working on this issue, please email Shannon Bader at this email address, sbader@prainc.com, and let her know that you're interested in more information. And as we firm up the plans for this learning collaborative, she can reach back out to you to see if there might be a good fit for your community joining this group. So if you are interested in learning more and participating in a several-month process focused on planning, launching, or strengthening AOT, please reach out to Shannon Bader. Okay, and just quick closing poll, if you would like to participate in that. I just want to say thank you again to Dr. Munitz for your time and sharing your expertise, and coming briefly out of retirement for a couple of hours to share your expertise and knowledge. It is very appreciated, and thank you so much, everyone, for your feedback in the chat. If you have any other questions, or if there was a question that was not answered and you really would like to answer it, get an answer, please reach out to us here at the Gaines Center. There's a toll-free number. You can also message us directly through the website, and we would be happy to link you with the appropriate person to get answers to your questions. That's what we're here for. We're here to help you find the information you need to implement and run your programs. So let me check on the certificate of attendance. I want to ask my team, will the certificate of attendance be going out in an email to all registrants? I know we talked about that as a possibility. Okay, so we are having some technical difficulties posting the certificate of attendance in the chat. I apologize. but we do have a new feature under Zoom where we can email everyone who participated in today's event. We will email you the certificate of attendance directly. So thank you very much. And we are at the hour. So thank you so much for joining. We hope to see you in 2026 for the next Games webinar once we get that on the books. And yes, happy holidays to everyone. Hope you have a safe and peaceful holiday for the rest of the year. Have a good afternoon.